From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. I'm Dr. Kristin Walter, Deputy Editor of JAMA, and I'm joined today by Dr. Kimmie Ng, who is Associate Chief of Gastrointestinal Oncology at Dana-Farber Cancer Institute in Boston, Massachusetts. Today we will be discussing a study that she co-authored with Dr. Tejas Jayakrishnan titled Early-Onset Gastrointestinal Cancers, a Review. This article was published online in JAMA on July 17th, 2025. Dr. Ng, thank you for joining us on this podcast.
Thank you so much for having me.
To start off, can you explain how early-onset GI cancer is typically defined?
So early onset cancer is usually defined as a GI cancer diagnosis that happens under the age of 50. And this is largely actually arbitrarily determined and historically was set based on the screening age for colorectal cancer being age 50. And certainly some of the early onset gastrointestinal cancers we'll be talking about today typically have a much later age of diagnosis. So anything that is diagnosed under the age of 50 is considered early onset.
And your article focuses on the three most common early onset GI cancers, which are colorectal, pancreatic, and a gastroesophageal cancer. Can you discuss the recent trends in incidence of these early onset cancers in the US and globally?
Yes. So actually, outside of GI cancers, there are actually many different types of cancers that have been increasing in people under the age of 50. But as a group, gastrointestinal cancers represent the largest digestive system of early onset cancers that has been rising not only in the United States, but around the world. And this issue of early onset cancer really came to light recently with the recognition that colorectal cancers were being increasingly diagnosed in people under the age of 50. So ever since the mid-1990s, there has been an increase of about 2% per year in both colon and rectal cancer in both men and women. And the reasons for this are largely unknown. Similarly, along the same time frame, we have recognized that the incidence of pancreatic cancer and esophagogastric cancer, as well as many biliary tract cancers and appendix cancers, have also been rising in very young individuals. And the key theme kind of threading through these cancer types rising in the young onset population is that many of them are linked to obesity and other environmental factors. And so there's a lot of research going on right now about what the underlying causes may be for this rise in early onset cancers.
So that leads to my next question, which was, can you discuss some modifiable risk factors that are associated with early onset GI cancers?
Yes, and I will first backtrack a bit to explain why we think it is environmental factors that are largely associated and underlying this rise in early onset cancers. And it is because if you look at the epidemiologic trends, they seem to follow what we call a birth cohort effect, where the risk really seems to vary and travel by generation. And when we see a pattern like that, it usually indicates that there is some recent exposure in the environment or change in exposure in the environment that's likely accounting for that generational variation in risk. And so with all of these gastrointestinal cancers already having strong links and associations with multiple modifiable risk factors, it is a top area of investigation to determine exactly what environmental exposures are at play. And for many of these, obesity has been the leading hypothesis given the rising rates of obesity in the United States and worldwide around the same time that seems to parallel the rise in incidence of these early onset gastrointestinal cancers. But we also have evidence, particularly strong for colorectal cancer, that dietary patterns, such as consuming a Western dietary pattern, as well as sedentary behavior and lifestyles, also seem to be associated with a significantly higher risk of developing these cancers at an age under 50.
Great. And what are some non-modifiable risk factors associated with early onset GI cancers?
So probably the most common is having a family history of the cancer. And the family history can either be in somebody diagnosed under 50 or over the age of 50. But when we look at studies of colorectal cancer, pancreatic cancer, and esophagogastric cancer, the younger patients have a higher prevalence of having a family member who was diagnosed with the same disease compared to older onset patients. Another very important non-modifiable risk factor is a germline predisposition to developing the cancer. And for colorectal cancer, the most common genetic condition is Lynch syndrome. And although the vast majority of these early onset gastrointestinal cancers are not considered hereditary, there is a much higher likelihood of finding a genetic predisposition the younger you are diagnosed.
And what percent of patients with early onset GI cancers have pathogenic germline variants? And should all patients with early onset GI cancer undergo germline and somatic genetic testing?
So the prevalence varies a little bit depending on which gastrointestinal cancer we're talking about. For colorectal cancer, for example, up to 25% of young onset colorectal cancer patients are ultimately found to have a pathogenic germline variant that likely contributed to why that young person developed cancer. For pancreatic cancer, it's probably up to 30% that are found to have a germline variant, such as in one of the BRCA genes, or commonly referred to as BRCA genes, or PALB2, that has contributed to why they developed early onset pancreatic cancer. And so because the chance of finding a germline predisposition is so much higher among younger patients compared to older patients, it is recommended that all young patients diagnosed with cancer under the age of 50 undergo germline genetic testing to identify these syndromes.
And how are the genetic testing results used by clinicians?
So germline genetic testing most often does not necessarily affect the treatment of the patient in question, although with the advent of emerging novel therapies, that is actually changing. So I'll give you an example. For colorectal cancer, if you are diagnosed with Lynch syndrome, the type of colorectal cancer that happens in the context of Lynch syndrome is what we call a cancer with high microsatellite instability. And we now have immune checkpoint inhibitors that are extremely effective against microsatellite instability high cancers. And so more and more, we are able to modify and tailor treatment for patients with identified genetic syndromes based on just identifying that syndrome. The same goes for pancreatic cancer. If there is a BRCA1 or 2 mutation found, we now have drugs like PARP inhibitors, which have significant benefit in that molecular subset of patients. In addition, though, identifying these syndromes in families can significantly enable cancer prevention and early detection in family members, because cascade testing of family members is highly and strongly recommended, and screening begins earlier for patients who are part of families with a known genetic predisposition.
And your article states that early onset GI cancers are typically treated similarly to later onset cancers, but there are often differences in terms of intensity of treatment. Can you discuss this further?
Absolutely. So there have been a lot of studies trying to identify whether there are unique molecular alterations or biological differences between younger onset cancers compared to older onset cancers. And at least for colorectal cancer, there is no home run in terms of a unique somatic genomic variant, for example, that really distinguishes young onset cancer from older onset cancer. And so because in general, we don't have known molecular differences between younger patients and older patients, the guidelines recommend the same type of medical treatment and approach to treatment for younger patients and older patients. For example, the NCCN guidelines do not distinguish the type of treatment being administered by the age at which these patients were diagnosed. However, we all know, and for those of us treating these patients, that the younger the patient is, and usually the healthier they are, there is a tendency to have them get more aggressive treatment, and the patients themselves also often want more aggressive therapies. So for all of these early onset GI cancers, we see patients being treated with more intense combination chemotherapy. They often undergo surgical resections more often, and they get targeted radiation treatments more often. But I think what is concerning is that when you look at the outcomes of these patients, the survival is not necessarily correspondingly superior with all this additional treatment compared to an older onset patient. And so that does make us wonder whether there are additional molecular and biological features that have just not been discovered yet that may be making these cancers slightly more aggressive when they happen in a younger person.
Patients with early onset GI cancer may experience specific challenges because of the stage of life in which they're diagnosed with cancer. Could you discuss some of those difficulties and how these patients can be best supported?
Absolutely. And while we know that it is very difficult and challenging to receive a cancer diagnosis, no matter what age you are, when a person is diagnosed in their 20s, 30s, or 40s, definitely there are unique challenges faced by these younger patients. There are documented much higher levels of psychosocial distress, depression, and anxiety among younger patients diagnosed with cancer compared to older patients. They also often experience more financial toxicity, and they more often experience disruptions in their education as well as their career. Another really important, unique aspect of being diagnosed with cancer at a younger age, under the age of 50, is fertility concerns. So many of these patients are either planning to still start a family or planning to still expand their current families. And because many of the cancer treatments administered do permanently impact fertility, counseling these patients prior to initiation of treatment about fertility preservation is hugely important for this population of patients.
Now I'd like to move on to the individual cancers that were discussed in your article. As you mentioned, early onset colorectal cancer is being diagnosed more frequently in the US and worldwide, and that dietary exposures are a really important modifiable risk factor. Can you discuss what studies have shown about the types of dietary patterns that increase the risk of early onset colorectal cancer?
Yes, some of our strongest data with showing associations between dietary patterns and risk of developing colorectal cancer, actually, regardless of what age you are when you're diagnosed, has to do with consuming a Western dietary pattern. And what a Western dietary pattern means is, the usual suspects that you would think about when you think about a poor quality diet. And that includes red and processed meats, a lot of sugars, refined grains, and high fat foods. And we have found in multiple prospective cohort studies that individuals who reported consuming higher levels of a Western pattern diet have significantly elevated risk of developing colorectal cancer, both at an age above 50 as well as an age below 50. Consistent with that, we've also done studies looking at consumption of sugar-sweetened beverages, which, as we all know, has also skyrocketed around the same time period as these early onset cancers have been rising. And again, in a prospective cohort study, this is the Nurses Health Study 2, we found that individuals who reported consumption of 2 or more sugar-sweetened beverages a day compared to less than 1 sugar-sweetened beverage a week had significantly elevated risks of developing young onset colorectal cancer. And so there have been a variety of other studies as well that have shown things like pro-inflammatory diets to be associated with higher risk as well. And so all of the evidence is really consistent in pointing to diet as being very important in risk of developing young onset colorectal cancer.
And in terms of screening for colorectal cancer, can you discuss the most recent U.S. Preventive Services Task Force recommendation about when screening with either stool-based test and or direct visualization using colonoscopy or flexible sigmoidoscopy should be initiated for average risk individuals?
Yes, absolutely. And this was a huge change in national screening guidelines when the U.S. Preventive Services Task Force issued their updated recommendations back in 2021 and published in JAMA. What they found was that through modeling studies, given the rising rates of young onset colorectal cancer, they found that the risk benefit was in favor of lowering the screening age to start colorectal cancer screening from age 50, which it had been for many years, down to age 45. And indeed, it does seem that from recent colonoscopy registry studies, for example, that the burden of finding adenomas and colorectal cancers in that 45 to 49-year-old age group does seem really similar to the age group that is above the age of 50. And so it is reasonable to think that there will be prevention of early onset cancers as well as earlier detection of young onset cancers with these new guidelines that decrease the screening age from 50 to 45. I will say this is really different across the globe. And actually, most countries in Europe and Asia actually still have screening starting at age 50. And in these other parts of the world, in contrast to the United States, where colonoscopy is the most often utilized screening method, in these other regions, it's most commonly with stool-based tests that colorectal cancer screening is performed.
When should screening start for young individuals who are at higher risk of colorectal cancer, such as those with a family history?
That's a really great question. And I think it's really important to point out that these screening guidelines that we have just discussed are meant for average risk individuals who don't have any of the known risk factors and who also do not have symptoms that are concerning for a colorectal cancer diagnosis. Some of the high risk factors include having a family history, having a known genetic predisposition to colorectal cancer, or having conditions like inflammatory bowel disease make a person no longer average risk. And in those individuals, screening should start at an earlier age. And the exact age at which to begin depends a little bit on the exact risk factor. But in general, if there is a family history of colorectal cancer, it is recommended that family members start their colonoscopy or stool-based screening at an age 10 years younger than the age at which that family member was diagnosed, or at age 40, whichever is earlier.
And moving on to early onset pancreatic cancer, what are important risk factors and how common is this diagnosis?
So pancreatic cancer is unfortunately becoming more and more common, both in older individuals and in younger individuals. And unfortunately, mortality rates are rising as well. Currently, it does seem to be increasing in the United States, more so for women than for men. And it does seem to be a global phenomenon as well. Right now, it encompasses about 5% of all pancreatic cancer diagnoses in the United States. And what is known about the risk factors are that many of them are similar to risk factors for pancreatic cancer in individuals who are diagnosed at an older age. So these include modifiable risk factors such as smoking and alcohol consumption. Individuals with a family history also have a significantly higher risk of developing pancreatic cancer. And then actually having a new diagnosis of diabetes or worsening of a diabetic condition can also potentially indicate a pancreatic cancer diagnosis.
Is there any role for screening for pancreatic cancer among adults who are considered at average risk for pancreatic cancer?
So current guidelines do not recommend routine screening for pancreatic cancer for average risk individuals. However, several United States guideline issuing societies, as well as international societies, do recommend screening high-risk individuals, including those with known genetic syndromes, such as with the BRCA gene, or commonly referred to as BRCA mutations, or Peutz-Jeghers syndrome, as well as with people who do have a family history of pancreatic cancer. The screening modalities most commonly used include MRIs as well as endoscopic ultrasounds. And the screening age at which to start and the frequency of which to do this pancreatic cancer screening does vary depending on the exact risk factor that is relevant.
Great. And the third cancer your article discussed was the early onset esophagogastric cancer. Can you discuss a little about the incidence of that in the US and worldwide in recent years?
Yes, so esophageal cancer and gastric cancer are often combined in many of the epidemiologic studies that are looking at incidence rates and average percent changes in the incidence of these diseases. But I will say that it's predominantly gastric cancer that has been rising in younger individuals. And currently in the United States, early onset gastric cancer actually represents 10% of all gastric cancer cases. So this is a significant number of young individuals who are being affected. we do know that the types of gastric cancers that are rising in young people seem to be different than the types of gastric cancers that are rising overall, regardless of age. And these are typically the distal gastric cancers and the diffuse type gastric cancers, as opposed to the more proximal cancers, which have been documented more commonly among individuals of all ages. That being said, the incidence rates of esophageal cancer are also increasing in younger individuals, although that is far less common than gastric cancer. And as many of you know, esophagus cancer can be either adenocarcinoma or squamous cell carcinoma, and it does seem to be the adenocarcinoma subtype that is predominantly rising in young people.
And what are the most important risk factors for the early onset esophagogastric cancers?
So risk factors are likely similar to risk factors for overall esophageal and gastric cancer. So probably the most well-known risk factor is Helicobacter pylori infection, which has been classified as a known carcinogen leading to gastric cancer in individuals. And this is especially common in regions of the world such as East Asia. There have been studies that have shown that screening for H. pylori can actually reduce the incidence of gastric cancer in high-risk regions, as well as eradication of H. pylori infection can also significantly decrease the risk of developing gastric cancer. Other things include some modifiable risk factors such as diet, again, which is also important in a disease like esophageal and gastric cancer. And for this type of cancer, it's mainly consumption of smoked and salted foods, as well as pickled foods and salt-preserved fish and meat. That does seem to lead to a significantly higher risk of developing gastric and esophageal cancer. And in terms of non-modifiable risk factors, they're largely the same as what we've discussed for colorectal cancer and pancreatic cancer, which are mainly family history and having an identified genetic predisposition syndrome.
And in most countries, screening is not performed for early onset gastric or esophageal cancer, but it is performed in South Korea. Can you briefly discuss that program?
Yes. So rates of early onset gastric and esophageal cancer have actually not been rising as much as in other parts of the world because they do have a screening program in place. So in South Korea, biennial screening with esophagogastroduodenoscopy, or commonly referred to as EGD, or upper GI series screening, is recommended to begin at age 40 for all average risk individuals. This is probably the only country that does recommend routine screening for this type of cancer. In the US, the screening guidelines are really only for people who have risk factors for these diseases. And some of those risk factors include having chronic gastroesophageal reflux disease, being male, being an older age, white race, and having risk factors such as smoking as well as obesity. And then a condition called Barrett's esophagus is a known precursor condition for esophageal adenocarcinoma, and having a family history of that or cancer in a first-degree relative is also considered a risk factor that indicates that somebody should be getting screening largely with EGDs.
We've covered a lot of territory in this podcast, but before closing, is there anything else you'd like to mention that we haven't previously discussed?
I just think it's really important to be aware that early onset cancers are rising in the United States as well as globally. There have been documented studies that have shown significant delays in diagnosis among younger patients, and it's really important that prompt diagnosis happens so that these patients do not end up being diagnosed with advanced or metastatic stages of cancer, as they often are. And they do often end up with metastatic disease at diagnosis more often than older onset patients. And so further research is urgently needed to really decipher what the underlying etiologic factors are so that we can modify screening guidelines to a more risk stratified approach, where those who do have high risk factors and are at higher risk for these diseases may hopefully be eligible for earlier screening. Also, much more research needs to be done to identify better screening methods and early detection tests for these cancers.
Thank you so much for sharing your thoughts with us about this interesting and very important topic. I'm Dr. Kristin Walter, and I've been speaking with Dr. Kimmie Ng from the Dana-Farber Cancer Institute in Boston. You can find a link to this article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.